Management of acid attack victim. Acid burns are very challenging to manage, especially in homicidal cases as the face is targeted and eyes are affected. The eyes have to be given a priority after initial life-saving resuscitation. A detailed plan for the reconstruction has to be prepared and discussed with the patient and the caretakers. Continued management by the same team is helpful. At Shankar Nethralaya, with the support of various specialties of ophthalmology, vision rehabilitation could be achieved. Different methods of reconstructions are presented with a view to give ideas to an aspiring oculoplastic surgeon. What is vitriolage? Vitriolage is an active act of throwing acid with the intention to disfigure, maim, torture, or revenge. The acids commonly used are sulfuric acid, nitric acid, hydrochloric acid. How does acid produce injury? Proteins and fat get hydrolyzed, produces cell death. The skin becomes leathery, dry, and brown called eschar. The skin is lost, leaving a raw area. Depth of wound depends on the concentration of chemicals and the duration it was in contact. The severity of the chemical burns depends upon the concentration of acid, quantity, duration of contact, thickness of skin, and site of body. Burn causes tissue loss. Wound heals with contraction. Unless covered with skin, contraction leads to deformity and distortion. There may be extrinsic contracture or intrinsic contracture. Extrinsic contracture leads to tissue loss at a distance, progressive sparring in periorbital, forehead and cheek. Intrinsic contracture, tissue loss in affected area, secondary contracture of the skin. The stages are eschar formation, wound once the eschar is removed, bone exposure in deep penetration of acid. Management, initial and succeeding. First aid in managing a chemical injury is removal of the inciting agent, painkiller and sedation. Areas of affected skin should be copiously irrigated with water. Better to avoid neutralization of the inciting agent. If ocular injury has occurred, the eye should also be copiously irrigated, preferably with artificial tears. An ophthalmologist should be consulted. Eyes must be washed well with isotonic fluids. Artificial tear drops can be used to wash the eyes. If due to eschar the eyelids are stiff and eye cannot be closed, eyelids should be released immediately to cover and protect the cornea. Cornea should not get desiccated, and this release can be done in the emergency room. Initial wound management in the form of escharrectomy, that is excision of non-viable skin, cover with split skin graft or full thickness skin graft because depending upon the area. Flaps and protection of cornea is the most important thing. How does acid affect the eye? There is a primary damage. When acid falls into the eye, a direct injury which produces ocular burns. Secondary damage because of infection, desiccation of cornea, injury as the eyelids do not close, inability to close the eyes, ectropion, lag ophthalmos, loss of eyelids. Assessment of eyelid and facial burns, extent of injury, depth of injury, involvement of cornea and conjunctiva, involvement of periorbital structures, lag ophthalmos. In the healing stage, what happens? There is contracture, scar, deformity, pain, itching. In the late stage, psychological problem, socio-economic as well as systemic damage. Facial burn categories may be focal or diffuse burns, essentially normal face with or without contractures, or panfacial burns involving the entire face. Ectropion management is important. It is an abnormal eversion, outward turning of the lid margin away from the globe. Without normal lid globe opposition, corneal exposure, tearing, keratinization of the palpebral conjunctiva, and visual loss may occur. How does ectropion develop? There is shortening of the anterior lamella. In chemical burns, both anterior and posterior lamella, as well as conjunctiva and cornea, may get affected. The eyelids are totally at the mercy of the destructive forces of wound contracture and scar. The bony margins being the buttress, eyelids are pulled towards it. In the transverse plane, the lateral ends of the tarsal plates are anchored to the bony orbit through the medial and lateral tarsal ligaments. In the vertical plane, the tarsal plates are loosely attached to the periosteum of the orbital margin by the thin palpebral fascia. The only bony attachment of eyelids is through the orbicularis muscle to the medial margin of the orbit. The periorbital area suffers the most contracture. Recurrent contracture is most common due to pull of scar from forehead and cheek. Burns may be because of thermal, contact, chemical, electrical, or radiation. Now, how and when do we correct? In the acute stage, conservative treatment is required. Essentially, one has to put a lot of eye drops and clean the scorched eyelashes. Then, escharotomy to cover the exposed cornea. Excision of non-viable skin, and one has to put in a cover. Once ectropion has developed, release of contracture and resurfacing of the resultant raw area with skin cover. Which should be done first, upper or lower? One eye or both the eyes? One lid or both the lids? It depends upon the need. On the right side, as you can see, only the upper eyelid is corrected. On the left side, both lids with the tarsorrhaphy, and as the cornea was already damaged. If pretarsal skin is unscarred, incision is made on supratarsal fold. If pretarsal skin is scarred, incision 2 to 3 mm above the lash line. If the lashes are lost, incision should be at the junction of conjunctiva to skin. Incision can be deepened up to levator. If needed, levator aponeurosis can be incised. Overcorrection should be achieved. 3 mm of normal skin should be retained in the lateral canthal area to avoid purse string effect. Lateral canthus, incision is directed upwards, and on the medial side, Z-plasty for epicanthal fold. Aesthetic unit must be respected. How do we correct? We need to put skin. Split skin graft is used if there is a large area of the eyelid, like both the eyelids, and the chances of recurrence is high, and other areas of the face also are to be covered. Then we use a split thickness skin graft. Full thickness skin graft works best when the entire area of the supratarsal area is involved or is limited to the aesthetic unit above the fold in upper eyelid. In the lower eyelid, as the color match is better, full thickness skin graft is preferred. Limited area needs to be replaced. Recurrence is not expected, or a final correction is done. Full thickness indications. How do we anchor the skin graft? One uses silk sutures to anchor the graft, used as a tie-over dressing. It gives better opposition to the graft bed. One can use tissue glue to make the graft adhere more. Normally, the skin sutures are removed on the 5th day if it is a split thickness skin graft, on the 7th day if it is a full thickness skin graft. In the medial end, fishtailing should be done to prevent contracture. The release must be over-corrected. Lid sutures should be taped over the cheek to maintain overcorrection. Complete hemostasis of the graft bed must be achieved. Donor area. Ideal donor area should not have much of hair. Color should match. The sites for full thickness skin graft are medial side of arm, post-auricular region, supraclavicular region, or groin in children. Here you see a case in which ectropion of the lower eyelid was corrected. Incision was made in the subciliary region, release of the contracture, and a full thickness skin graft was placed over it. Ectropion of the upper eyelid, release and split skin graft. The scar over the cheek was also excised. Ectropion released both upper eyelids. Zplasty to scar over the cheek. Lag ophthalmos was corrected. Scarred pretarsal skin. Split thickness skin graft was placed as we needed large graft. And here you can see the patient is able to close the eye fully, though there is still a little bit of a lag ophthalmos on the right side. Unscarred pretarsal skin. Incision is made along the supratarsal fold. Full thickness skin graft is placed and one gets a good result. Care of the graft is very important. After removal of the tie-over dressing, if the graft take is 100%, it can be left open. Smear it with antibiotic ointment and massage to the graft is important. Silicone gel sheet should not be placed unless the wounds have healed completely, which will be in 2 weeks' time. Massage with oil or cream. Silicone gel sheet to reduce hypertrophic scar, and compression garments is important to give further pressure. What does the silicone gel do? It smoothens the grafted skin and edges. The exact mechanism is not known. It is proposed that gel goes into the crevices or irregular surface and produce some pressure effect. It's used for minimum of 8 hours and per day and for about 6 weeks. Ectropion of both upper eyelids, left lower eyelid, release and skin grafting, late appearance with good care of the graft, which you can see it in the last picture. What are the pearls? Minimum 20 millimeter of skin is required from the brow to lid margin for the eyes to close. Recurrence of ectropion in case of periorbital scarring is due to second degree contraction. So overcorrect the release. Correct the forces of contraction from forehead and cheek. Use ancillary methods like silicone gel pressure and massage. Leave medial and lateral canthal areas with normal skin. Both upper and lower lids should not be corrected at the same sitting. Both upper lids can be corrected in the same sitting. Full thickness skin graft does not preclude contracture. Timing of contracture release should be individualized. Priority has to be given to protect the eye first. One eye or both the eyes. Masquerade procedure. Masquerade means false show or pretense. Masquerade procedure is done to cover the entire globe and protect it. When there is ectropion of both eyelids to protect the eye, the conjunctiva is released and dissected. A total tarsorrhaphy is done and the raw area over the eyelids is covered with the skin graft. Tarsorrhaphy is released after 4 to 6 weeks. Here you see the release on both the sides. A total tarsorrhaphy was done and split skin graft for the upper and the lower eyelids. Another case, here the release of the conjunctiva and it is turned upside down and sutured like a total tarsorrhaphy over which split skin graft was placed. The release of the tarsorrhaphy on the right side alone could be done as the left side was beyond any improvement. Sometimes we have to use a flap. Here there was a tremendous shortage of conjunctiva, so we used a mucous membrane graft for lining the flap. Flap from both the foreheads was transposed over the eye to protect. Here you see Thesical eye. There is a shortage of conjunctiva. Mucous membrane graft was placed over it and a median forehead flap was done to cover this area. Before any eye surgery for vision, the lids must close well. Here you see an ectropion of all the 4 lids and microstoma was released and forehead wound was covered as if there was a bone graft, exposed bone there. Lid margins were available in this particular case and could be preserved. Conjunctiva was dissected and split skin graft of both upper and lower eyelids were done. Finally, patient had undergone Boston keratoprosthesis. The left eye was Thesical. When I see a case of acid burns, I get shocked at the cruelty. I feel frustrated and disgusted and feel that no amount of punishment is enough for the perpetrators. But the perseverance of the patient makes me persist with the reconstruction. This young lady had an vitriolage injury. She had Both the eyes were exposed, and this is after the first escharectomy with split skin graft. Another lady with a post-acid burn face. Multi-stage reconstruction was done, and here you see the patient after 6 years and later after 14 years with complete reconstruction. And here you see another patient who had a multi-stage surgeries with contact lens on the right side.